real innovations in value-based payments in the home healthcare arena. Welcome to the CarePayments Pod. I'm Fady Sahhar, president of XtraGlobex and co-author of Value-Based Payment Blog and Dual Eligible HQ. Today, we're privileged to have with us Dr. Michael Johnson, Chief Researcher of Home Healthcare Innovations at Bayada Home Healthcare. Welcome, Mike. With 30 years of innovation and leadership in home healthcare, tell us about the highlights of your journey.
Yeah, well, thanks first of all for having me. As I've learned over my career, how much you get paid matters, but how it's structured sometimes matters as much, if not more. And so excited to have the conversation. So I'll give you a little bit of my background and how I got to where I am. So I'm a physical therapist by profession. Back when you could get a PT degree as a bachelor's degree, it's all entry-level doctorate now from Northeastern University. I went back to school after a few years to get my master's, specifically in orthopedics, PT. My master's thesis research was on three-dimensional motion analysis of the scapula, right? So getting really deep into clinical practice, right? Otherwise known as the shoulder blade. And I was going to, I stepped into academia and I was planning on being there a long time. So I was getting my PhD. I was going to get it in biomechanics. And then some legislation went into effect in 1999 that really impacted the ability of physical and occupational therapists to get employed. So there was some payment change. And what I realized was if you don't understand how this broader system works, delivering good care. So being a really good clinician matters, but it's not the only thing, much to my chagrin, right? There's payment, there's policy, all that sort of stuff. And so I ended up getting my PhD in health policy. I was an academic faculty member for 10 years, and I left the academy because I was too far away from the action. It was around, in 1999, for example, the book To Err Is Human came out and really opened up our eyes in terms of there was a lot of error in healthcare. And so that became a passion for me. I've had a fun run. We can talk a little bit about that. But I eventually went back into the health system where we had done some, we had gotten some grant funding from HRSA, the Health Services Resource Administration, and opened up clinics for the uninsured, fitness and wellness clinics, which is, so I was interested in how do you get that? How do you take care of communities? And then found my way to Bayada, 10 years of running the home health practice, so high-level operations, and then recently in a new role as chief researcher.
Wow, that's an amazing journey. When we chatted before, you shared several examples of innovations, particularly as it relates to value-based payments in the home healthcare field that you've been involved in. What have you found to be the most critical elements that make for successful and effective value-based payment program in this sector?
I think probably a couple things that I've learned along the way. We talk a lot about alignment of incentives, and it's usually payment incentives. And I do think that matters, right? Currently, Medicare has all of the home health industry on a value-based model called home health value-based purchasing. Right? It has three specific elements, all three of which mirror the triple aim. So quality of care, cost of care, and the patient experience. So that's important. I think there's also a concept that I refer to as emotional alignment, because what you're doing is you are asking clinicians, and in Medicare certified home health, you've got nurses, physical therapists, occupational speech therapy, social workers. And most of these folks have entry-level master's or doctoral degrees. And I say that not because they're smarter than anybody, but they've made an investment in this profession, and they want to be included in the conversation. So if somebody says to me, do this because I said so, it doesn't work very well. I get my Irish out. So how do you help clinicians understand why we have to make some of these changes? Because the reality is the dollars do matter. And I call that sort of emotional alignment. And really, you've got to figure out how to inspire them to do more with less, because I think we can in many instances, but also make sure that they understand that this is all about good patient care and outcomes, because they'll very quickly go, this is all about profit, right? There's probably 2/3, I think at this point, of home health organizations, and almost 3/4 of hospice organizations are for profit, which isn't necessarily a bad thing, but it does indicate that clinicians take that as it's all about the money. And so you've really got to work with your clinical staff to have them understand, while it is about the money, at Bayada we say you lean left, people, service, and quality, give a really good experience, really good clinical outcomes, and the rest will follow, which is to the right, grow and have enough pennies left over to reinvest. The final thing that I'll say for this question is you have to think about, and this was a lesson that I learned through my career. If you want good outcomes, you've got to walk back to figure out what do you need to do to get those outcomes. And so many of your listeners will be familiar with the Donabedian framework for quality, right? So there's outcomes, but upstream from those are structures and processes. And so you've really got to think about how do you impact the structure and payment is a good example of structure, and then processes that are going to likely get us better outcomes. So screening for fall risk is a good example of a process measure that would get there. So you really do have to step back and think about this globally and then help bring it back to the clinician as to here's what we're doing, here's why we're doing it. And in the end, it will help us get better clinical outcomes, and they'll be with you. But if you quickly try to put this stuff together without walking people along change management, you're going to get a lot of resistance. And I think that's where we run into trouble across healthcare lots of times with these initiatives.
Yeah. Yeah, it's interesting you say that, because we've also found that awareness of the need for structure and process as you get to the outcomes is something we have to educate folks on, because they want to jump to the finish line.
Right.
But you've also, as we talked in other conversations, you've emphasized the importance of integrated care, and we're finding increasingly that certain parts of our system are more likely to have resources to support better outcomes than others. So, can you share with us one of your case studies or examples where you've seen that work for you?
Yeah, so one of the, and I particularly appreciate this question because I think it goes back to what payment allows you to do or makes it harder for you to do. And so there's a program that we implemented several years ago with a hospital and a health system in North Carolina that had its own ACO, right? So that allowed it to be the payer and the provider at the same time.
Mm-hmm.
And what we did is the program was called Directly Home, right? Maybe not that creative. It was how do we get people directly home and avoid expensive inpatient post-acute stays, skilled nursing, for example, if appropriate. So these were folks that were eligible for SNF, so there's a higher level of acuity, but we were bringing them directly home. The innovation here was adding a upfront, what I'll say is, to use a medical term, a bolus, a whole bunch of home health aid services to manage what I'd say is not their clinical condition, but their expectations and their anxiety. When people are transitioned back home, they're afraid. Right, and if their loved ones are afraid, and when you're afraid, you're going to make quick snap decisions, and everybody knows how to dial 911. So how do we manage that? And so Medicare is not set up. Home health is not set up for 24-hour home health aid services. That's not part of the benefit. But what we did is the ACO paid for the home health aid services. Really call it 24 hours a day for the first day or two, then down to 12, and then down to 8. And within about 2 weeks, that home health aid was out of the picture, but had helped them manage their expectations, get settled all the time while the home health nurse, the PT, the OT were doing their thing, and the aid could sort of pull that through. It doesn't sound, when you say innovation, you expect this incredibly new thing. This is just good common sense, quite frankly. But there's no payment mechanism for it, except in this case, the ACO was willing to pay for the home health aid services.
Right.
And what we found was the satisfaction of the patient and the family was much higher. So we got good. So that's part of the triple aim. The costs were lower. With the first 200 people we had go through the program, we saved that health system just shy of $2 million.
Wow.
And the outcomes were good. We had a lower readmission rate for a higher acuity population than the state average. And so this is really just, we call it social determinants of health, call it human factors, whatever it is. There are elements of taking care of people that aren't captured in an ICD-9 code that we've got to figure out. And so that's one where we're really excited about what we've been able to do. But now the payment model still doesn't allow that to happen. So how do we continue to try to shift things?
And we're finding that this integration of being able to bring traditional physical health to the applications in what is considered non-medical home care, and in some situations can be so vital to
That's right.
not only the ability to deliver better outcomes, but to sustain the person in the community longer, even in sporadic services that they might receive. And I just want to poke one more question at you. This came up. We had the what I found interesting is that a lot of the medical models that have been out there are designed for episodic events
Correct.
versus some of the stuff that we're dealing with Medicare and Medicaid, where we have people that are with us for the long term. Have you had what's been your experience with that? Have you seen results that are effective, but in integrating both sides of the service arena?
That's a little bit more challenging because we've got modes of care that are episodic. Medicare certified home health, 60-day episodes. You can have multiple episodes, as you know. And then what I think you're referring to is sort of longitudinal care management,
Hmm.
right? How do we keep an eye on clients and families without necessarily having to shower them with medical services the whole time, because they don't necessarily need that full time. But what our system seems to be set up for is, let's get them better. Let's wait until they start to decline. Let's actually wait until they crash, and then we'll that's, we got acute care and we'll do it, because the payment structure is set up to, there's no payment to jump, or there's not as many examples of payment. There's some that are
Hmm.
evolving to intervene as we start to see them crash, right? So
Yeah.
one of the things we've been working on, um, and we've eight at Bayada. We have 8 specialty practices. We call them business units. One is private duty home health aid services, and one of the things we've been doing there is working with with a partner to create a risk model, so we can start to identify when they were before they crash,
Hmm.
and intervene. And one of
Yeah.
the things that we've been able to do is actually identify folks that are at risk for falls. And we've started a pilot program for the last 4 to 6 months. And we've actually seen a 40% decrease in injurious falls, which we believe will translate into less hospital admissions and overall savings, even when we're in there for a private pay event. So to try to figure out how do you match these things together to get better outcomes is still a lot of work to be done.
Yeah, we had similar experience. I was working on a project where we were able to monitor individuals who were diabetic, and
Mm-hmm.
just by tracking them and providing coaching to that consumer, they were able to prevent some serious events that could have transpired. You know, Mike, this is the kind of conversation that we should start making our podcast go for half an hour or an hour, because you and I can talk for a long time. So as we're getting ready to wrap up, what would you like to leave our folks with? Any last
Yeah,
thought for our team?
yeah, I'll leave with an example of the structure, process, and outcomes piece that I talked about in the beginning. So we've got a home health practice and we've got a hospice practice, and we know that there are folks on home health who really should be on hospice. And how do you identify them, and how do you make that assessment, and then how do you have a conversation with them? And keep in mind, these are business units. We've got to hit budgets because we've got payroll and so forth. So what we found was that the folks that were really hospice eligible but were under home health, there is a little bit of a disincentive to transition them to hospice because you lose the revenue.
Sure.
You're like, okay, well, and it isn't all about the revenue, but it is to some degree. And so I don't want to sound like people were mercenary, but what we were able to identify for the directors in home health, those were the same patients that were driving up your hospitalization rates. And
Mm,
with home health value based purchasing, preventable hospitalization is actually a measure. We can actually improve your outcomes by doing the right thing for the patient. And what we had to do to make that work was we actually had to create a role called the care transitions manager that helped
mhm.
talk to the home health practice and do that. So sometimes you've got to build bridges between these services, even in an organization where we're all on the same team. It's not an easy thing to do. And so that's where the structure, process, and outcomes, it provides a framework to think about how you would do this stuff. So
Excellent.
that would be my parting thought: is don't give up, think big, and use
Uh,
some structure to connect things that maybe haven't been connected before.
well, Mike, it's really been a pleasure to have you with us, and I hope you'll come back in
We'd
the
love to.
future. And because this has added some really essential elements that, as we go to conferences and talk to clients and our organizations, we have to sometimes go back to basics. So Thanks very much for your time and input, and to all of our listeners and audience members, as always, onward.
The CarePayments Pod is brought to you by XtraGlobex. XtraGlobex is a strategic consulting firm that works with companies that are at an inflection point. We work with organizations to help manage that change and meet your goals. What is your challenge? Let us help take you onward. Link in the bio for a free consultation. Visit us at XtraGlobex.com.